Good day. Welcome to this briefing to launch the Safeguarding Health in Conflict Coalition annual report on violent attacks and other threats against healthcare in conflicts, which covers 20 countries and territories. Thank you so much for joining us today. I'm Susanna Sirkin, Director of Policy at Physicians for Human Rights. Today, as a member of the steering committee of the Safeguarding Health in Conflict Coalition, I'm honored to moderate this panel discussion. We will highlight the report's key findings and recommendations. We'll hear insights coming from the front lines and discuss emerging trends about attacks against health in the era of COVID-19. The Safeguarding Health in Conflict Coalition is a group of more than 40 international non-governmental organizations working to protect health workers and infrastructure around the world. Along with our coalition co-sponsors, I want to thank the UN missions of Norway, Poland, Switzerland, and Uruguay for co-sponsoring this launch and for their long and continuing efforts for the protection of healthcare in conflict. They have been steadfast in their commitment. The information in this report is the result of the efforts of many contributors, and the work was carefully coordinated by Carol Bales and her colleagues at coalition member organization IntraHealth, who persisted when the pandemic changed the way we all work. We are releasing this report at an extraordinary and unprecedented moment in history, when, sparked by a brutal killing by police of a Black man in the United States, George Floyd, people in almost every country in the world have gone to the streets and onto the airways to protest against violence, against uncontrolled and excessive use of police and military force, and against racism and discrimination. They are protesting for fundamental human rights. I should note that in the past few weeks in cities in the United States, we've received reports of medics providing care to injured protesters who have also been assaulted by police and arrested. These are incidents we're currently monitoring. And all of this has happened in the midst of a global health crisis that has taken the lives of at least 400,000 people and pushed even well-resourced health systems to the brink, while also exposing underlying inequities affecting the health and well-being of populations. This report that we're launching right now is also about impunity and violence that dramatically and cruelly affects healthcare and health, and what we as a global community can do to stop it. The world is waking up to the crucial roles of health workers in our communities everywhere. But while health workers around the world receive well-deserved tributes and recognition for their heroism in the COVID-19 response, they also face, in many places, aerial bombardment, targeted violence, kidnappings, and threats to their ability to provide impartial care to those in need. Health workers around the world face attacks stemming from ongoing violent conflicts and political unrest, as well as attacks specifically against COVID-19 response efforts. We recognize that it is nurses who comprise the majority of the health workforce worldwide, and they're often the first and only point of care in many communities around the world. So this year, in recognition of the 2020 International Year of the Nurse and the Midwife, the coalition has dedicated the annual report to the nurses and midwives who work every day on the front lines in conflict settings to promote health and save lives. During the next hour and 15 minutes, we will hear from the coalition chair and a leading author of this report, Leonard Rubinstein, who is a professor at Johns Hopkins Bloomberg School of Public Health. He will give a brief overview of the report's findings, analysis, and recommendations. We had planned to have a nurse from Yemen on this panel who has experienced these violations while trying to deliver care on the front lines of what has now become the world's greatest humanitarian crisis. Unfortunately, due to the ongoing situation there and connection challenges, the nurse was unable to join us. But we are very, very pleased to have coalition member Dr. Zahr Salul, director of MedGlobal, speak about the situation there and other countries where he and his colleagues work. And then we'll hear from Christina Wille, managing director of Insecurity Insight, which collected and compiled the incident reports. And she will speak about the data we have presented here and will share for the first time new data collected just in the past few weeks and months on violent incidents against health workers in the context of the COVID pandemic. Before we open up for questions, which you can ask through the Zoom Q&A chat at the bottom of your screen, we will hear brief statements from government co-sponsors with us today, representing Poland and Uruguay. And at the end of our session, we'll hear from the representative from Switzerland. We thank you so much for your participation and your commitment to concrete action as we work towards a world where every health worker in every community is safe to save lives. I'm now pleased to introduce Len Rubenstein, a mentor to me and many other advocates for health and rights, who's done so as much as anyone to put a spotlight on these issues. Len?
Thank you, Susanna, and good morning, good afternoon to everyone. And I'd like to add my thanks to our co-sponsors from Norway, Poland, Switzerland, and Uruguay, as well as colleagues in the Safeguarding Health in Conflict Coalition. What our report found is the scourge of violence against healthcare in conflict seems to know no end. In 2019, we found more than 1,200 incidents of violence in 20 countries, each of which is described in a database accompanying the report and is available online. The violence was committed by state forces and non-state armed groups with different targets, motives, and weapons. The results of the violence were at least 150 health workers killed while doing their jobs and more than 200 health facilities damaged or destroyed. We have good reason to believe that the numbers of incidents we report are actually lower than the actual number. We base our data on individual incident reports collected by the WHO, NGOs, and reliable media. But these sources are limited. The WHO surveillance system of attacks only extends to 10 places. In some countries, such as the Central African Republic, few incidents are sent to the global database. Globally, certain types of incidents, such as threats and obstruction, are almost never reported, despite the enormous impacts they have. In Afghanistan, for example, the WHO reports that about 200 health facilities were forced to close because of threats, but we lack incident report details on these incidents, so they are not included. Even so, the report reveals some alarming trends. I'd like to highlight 6 of them. First, we now have abundant evidence of how violence impeded domestic and international efforts to control the Ebola outbreak in the Democratic Republic of Congo. We found more than 400 incidents of violence against healthcare in the DRC, most of them in connection with efforts to scale up responses to the outbreak in North Kivu province. At least 24 health workers were killed there, and various aspects of the epidemic response had to be suspended or limited at times because of the violence. There's little doubt that the violence prolonged the outbreak and led to many excess deaths. The implications for addressing an outbreak when responders themselves are targeted has obvious implications for COVID-19. Second, in 2 countries, Afghanistan and Syria, Very high levels of violence against healthcare have persisted year after year after year. The contexts are very different, but the targeting of healthcare, whether to deny care to claimed enemies, to change the strategic calculus, to gain tactical advantage, has been a constant since these wars began many years ago. This year, we report more than 100 incidents in each of these countries, each one inflicting profound harm on health capacity and access to healthcare. For health workers in these countries, the persistence of the violence has led to despair and resignation. A midwife in Syria recounts in the report that, quote, when an airstrike hits, a chaotic scene unfolds right before your eyes. Children start to cry. We try to keep everything under control. It's emotionally draining and exhausting, but we have no other choice. We're used to it. What can any of us do? When death falls from the planes in the sky, we can only watch. The third theme is that newly escalating conflicts have been accompanied by increasing violence against healthcare, such as in Libya and Burkina Faso. In one airstrike by the Libyan National Army, we identified more than 13 health workers killed or injured. There were more than 70 incidents in total. In Burkina Faso, 19 health workers were kidnapped. Fourth, and this is also highly relevant to the COVID-19 pandemic, disruption, torture, shooting live bullets, arrests, and other forms of violence were inflicted on health workers in volatile situations of political protest. In Sudan, security forces arrested and tortured health workers, stormed and fired tear gas into hospitals, raped female health workers, and killed a doctor. In Iraq, anti-riot police destroyed a medical tent and fired tear gas at an ambulance. In the occupied Palestinian territory, Israel continued return protests, wounding more than and death. Immunization continues disrupted. Pakistan had to spend polio tax, and as a result, almost 2 million children. The community has continued with evidence of Syrian responsibility for targeting hospitals on the so-called deconfliction list there. But no country found that Israel had consistently failed to conduct meaningful investigations of breaches of international law by its troops. In Sudan, a new constitution requires transparent and thorough investigations, but maintain laws that provide immunity to security forces for acts committed in the act of duty. The data we collect only addresses the immediate consequences of attacks, not their reverberating effects on health access and outcome. But I'd like to share with you some data from the UN on 2 countries that shows their calamitous impacts. We have spoken today about health workers, but it is the wounded and sick who suffer the most. UN OCHA calculated that 24,000 hours of healthcare delivery were lost and 41,000 consultations missed in Afghanistan due to forced closure or destruction of health facilities. The health cluster for northern Syria projected in March that as a result of attacks that destroyed half the health facilities in northwestern Syria, in a 4-week period, outpatient consultations would likely decline by 133,000, and that 11,000 trauma patients could not receive the care they need. This violence has long been deemed unacceptable, even intolerable. It has been 4 years since the Security Council adopted Resolution 2286 and reform the laws, improve military doctrine training, strengthen investigations, and vigorously pursue accountability. These commitments have been made year after year in all kinds of forums and through resolutions and declarations, but they are not implemented. We call on states and non-state armed groups claiming to be devoted to the protection of healthcare to take these actions to which they committed. We believe they must be accountable for taking these actions. It can be done by non-state armed groups by signing Geneva Call's deed of commitment on the protection of healthcare and agreeing to monitoring their compliance. States should report the actions they take and be subject to review. And they must do all in their power to hold those who commit war crimes against the wounded and sick and their caregivers to be investigated and prosecuted. I'll now turn back to Susanna.
Thank you, Len. I'm now deeply honored to introduce Dr. Zahr Salul, a Syrian-American physician and co-founder and chair of MedGlobal, a humanitarian organization that works in conflict countries around the world. Thank you, Zaher, for joining us and for your incredible work. And also, we're so glad to see you healthy, having, as you said, been targeted by COVID-19. It's great to have you with us.
Well, thank you very much, Susanna, and thank you, Len, for the introduction. It's my honor to be in this panel, and I would like to start by saying that I'm healthy. I recovered from COVID infection. Like many of my colleagues, this is the untold story here in the US, that we had many healthcare workers that were infected and targeted by COVID. Some of us unfortunately died. I was looking at the numbers that a healthcare worker died because of COVID in the US. We had about 600 in some estimates by the Guardians, which is a huge number for a country like ours. And of course, we had many colleagues in Italy and Spain and China who died also because of COVID. I'm a critical care specialist in Chicago, but I did an organization called MedGlobal that we work in mostly disaster regions in war countries and countries with low resources to build resilience within the local communities. And I'm just going to mention some of my observations and stories. I worked in Syria myself and also in Yemen. Our last actually medical mission was in Yemen in November of last year. 22 physicians from 8 different countries. We went to an area called Hadramaut in east of Yemen, which was a little bit away from the fighting. But I've been in areas like Ma'rib and Ta'az and Aden, where it was fighting and targetings of healthcare facilities. And one of the hospitals that I worked in, which is the General Ma'rib Hospital, was bombed by one of the parties, and few physicians and nurses were killed because of the bombing. We provide with MedGlobal training and medical supplies and medications to local physicians so they can weather the storm. We always imagine that in these areas of war that people are desperate and fleeing and there's displacement and there's shortage of healthcare providers, and they are all of that. One of the main reasons that people are displaced in countries like Yemen and Syria is the attacks on healthcare providers and the attacks on hospitals. But also there is a lot of resilience. There is a lot of good stories to be told. There is a lot of people who want to continue to provide healthcare to their communities in spite of the attacks on them and on their hospitals. I remember in the city of Aleppo, I worked in a hospital called M10, which was initially built above the ground like any other hospital. It was targeted multiple times by the Syrian regime. And then eventually the local communities decided to build it underground to protect the doctors and the nurses and the patients. My last mission in Aleppo in 2015, I worked in that hospital underground. One of the nurses who was with me, his name was Abu Rajab. He was a radiologist technician, and he continued to provide services to his community. That was his neighborhood, that was his hospital. One day in the fall of 2015, the hospital was targeted. He was in the middle of doing x-rays in the patients, and he was injured badly, and fortunately his life was saved. He was taken out. He spent a couple of weeks in the intensive care unit, and he recovered completely from his wounds. He continued to practice medicine. Right now he's working in Idlib, which is another epicenter of attacks on healthcare in Syria. I've seen extreme cases of communities that are trying to continue to provide healthcare, and doctors and nurses to continue to provide healthcare in spite of the attacks. Our colleagues in the Physicians for Human Rights probably going to tell us more about the attacks on healthcare in Syria, and that 580 hospitals were targeted, 925 doctors and nurses were killed, but people continue to practice, and they go into extreme cases to provide care. I worked in a hospital that was built in a cave in Syria, inside a cave, called the Central Cave Hospital in Syria, because community over there wanted to continue to provide healthcare to the villages around it. And the villagers refused to build the hospital inside the village, because they say that if your hospital will be targeted, that means the neighborhoods and the civilians in the village will be targeted. So that's why they chose to build it inside the cave for protection. There is a picture, I don't know if I will be able to show it, of one of the medical missions. Let me see if I can show this. So this is a hospital in north of Aleppo called the Kindy Medical Center, which was one of the largest medical centers in Aleppo. I visited it in 2015 with a group of physicians from Chicago, and it was completely destroyed. It was attacked actually by both parties, the government and the rebels. And it was the largest medical center that's serving north of Syria. And as you see, the ambulance and the hospital was completely destroyed. And that means the local population were deprived of specialists, were deprived of oncologists, were deprived of surgery that this hospital was also providing. One more picture I would like to see is one of the nurses that I worked with in M10 hospital. His name was Muhammad. And he was, I don't know if you're seeing this picture, but this is a picture of a hole that was digged in front of the hospital in north of Hama. And the purpose of this hole inside the ground is to protect doctors and nurses when there's an attack on the hospital. So every few hours, there's usually fighter jets or helicopters in the skies, and people leave the hospital and go inside this hole in front of the hospital for protection. So this has happened frequently, a few times every day in Syria. Okay, this is a picture of Abdullah. This is a picture that I still remember vividly in my memory. This is a young child, 11 years old, who was playing in the neighborhood in Aleppo when a barrel bomb was thrown on the neighborhood. He had shrapnels in his chest, and he had fluid and air inside his lungs. And this nurse, Muhammad, on the left side of the screen, was trying to insert a chest tube on Muhammad's chest because to drain the air and the blood without local anesthesia. They were able to save the life of the child, at least for that time. Muhammad, the nurse that you are seeing on the left side of the screen, was killed in the hospital 1 week after that, when the hospital was targeted. So when we're talking about 925 doctors and nurses in Syria were killed, when we're talking about 120 times health attacks on healthcare in Yemen. One of them, for example, targeted a Thawra hospital in Taiz that was targeted 45 times. We're talking about real people like Muhammad. We're talking about very painful stories that are not only killing healthcare professionals and targeting nurses and doctors who are doing their humanitarian duty, who are serving their communities, who care about the civilians in the area, who care about medical neutrality, but we're talking about depriving the healthcare, the local communities from healthcare, from health, from healing, which means displacement of the local population and causing more suffering to the local population. Thank you, Susanna.
Zaher, thank you so much. This is such a grim reminder of everything that is going on in the countries that are mostly the worst affected, and especially by extremely violent attacks. And as you mentioned, Physicians for Human Rights has now, for more than 8 years, been documenting the intentional strategy of targeting health facilities and personnel, hundreds of attacks that are, in our opinion, crimes against humanity and must be prosecuted. And we'll talk about that later. But I also just want to note that in our interactions with nurses from Yemen, who we very much wanted to have with us today, they said in the context of what is going on right now with the coronavirus that there is almost no PPE, protective equipment for nurses and doctors, anybody who is working in the government-run hospitals. And they've experienced, as you mentioned, years of airstrikes and being forced to evacuate patients in these contexts. And as we know, the health system is almost totally decimated there. So in both of those countries, as well as Libya, they're all highlighted in the report, and I hope people will read in more detail both the terrible catalog of incidents, as well as think with us about what more we can do to stop. I'm now very pleased to introduce Christina Wille. Christina is the director of Insecurity Insight. And in addition to compiling and analyzing the data on attacks in 2019, she's carried out a Herculean task of gathering data in just these few weeks from dozens of countries on threats and violence against health workers in the context of today's global pandemic. Christina is joining us from Geneva, I believe, and thank you, Christina.
Thank you, Susanna, and thank you for everyone who's come today to listen to this important subject. Thank you to all the states who are supporting this important work. As Susanna said, I now want to say a few words on what we know about the patterns of attacks on healthcare in the context of the COVID-19 pandemic. And as it has been said so many times, the pandemic has really changed so many aspects of our life that we considered normal. Yet none of the underlying problems in our societies have disappeared because of the pandemic. And I think exactly that is also true when we think of the patterns of attacks on healthcare in the context of the pandemic. As we've already heard today, there were far too many attacks on healthcare during conflict in 2019. And as Zaher reminded us so eloquently of the cost this brings to the individual health workers and patients affected by it. And such violence has not changed. It has not gone away during the pandemic. It continues. And yet, at the same time, we're seeing a massive increase in additional violence on health workers that are a direct response to the health measures that are implemented to fight the pandemic. And I have prepared a graph here for you, which I hope you will be able to see, which gives you an idea of what we think has been going on in this year. You can see here the yellow tagged events that are conflict related, defined by the fact that the perpetrator was a member of a conflict party. And as you can see, 2020 pretty much started as 2019 had ended. But then we all became aware of the pandemic. And suddenly we see quite a stark drop in the reported conflict-related events shown here in yellow. Now, I don't know why this is. I can only speculate that the perpetrators of these attacks may have been just as surprised and confused by these sudden changes to all our lives and started to reevaluate their strategies. The unfortunate reality seems to be that just after a few weeks, the violence resumed. You can see here that the yellow-coded conflict violence has returned despite the calls for a ceasefire. We have seen bombings of quarantine centers in Yemen, hospitals treating COVID-19 patients have been bombed in Libya, health professionals attending meetings of how to protect people in rehabilitation have been killed on their way to work. An ambulance driver reported transporting test kits in Myanmar has been killed in crossfire. The same violence that we've seen last year continues. In some cases, it's now directly affecting the COVID response. But we're also having this big block in red here, and that is what we might sadly refer to as the new normal of the attacks on healthcare in the context of the COVID-19 pandemic. These are all events we have logged since the beginning of the pandemic that directly target health workers or health facilities with a direct link to the health responses required for COVID-19. We know of health workers who've been mourning the death of their colleague who's died of COVID-19 attacked during funerals. We know of health workers who've been violently attacked by patients who flee from quarantine centers. Security forces asked to respect testing or quarantine rules have assaulted health workers. Health workers have been assaulted by security forces trying to enforce the lockdown while on their way to work. Health workers have been arrested because they've spoken out about the lack of personal protective equipment, or because they mentioned numbers of COVID-19 patients they were treating that didn't tally with the official figures. The situation for health workers responding to the COVID-19 is very difficult in many countries. We identified such events in 61 countries around the world. One characteristic of these events is that the perpetrators are not the traditional conflict parties as we have monitored for so long. They are members of the community largely. And while we know that there have always been attacks by community workers and health workers, by community members and health workers, it is striking the number of reported cases. And I think it is absolutely true that this pandemic has led to an explosion of violence against health workers as we've not seen it before. It is happening around the globe, just as the pandemic is striking around the world. So this is a really important issue because it affects the ability of health workers to deliver primary health care, to prepare preventive policies, as well as to address the COVID-19 pandemic. And I'm very concerned that if the global community fails to contain the COVID-19 pandemic, in particular in conflict-affected countries, the virus will linger. And this will not only be dramatic for the populations already suffering from conflict. I think there is a real risk that this will transform the relationships between caregivers and people in need of help. We've seen that in South Sudan and Mali, the first people who tested positive for the virus were an aid worker and a peacekeeper. And I think there is a real risk if this virus continues in the conflict-affected areas, that it will be aid workers and peacekeepers who continue to transmit the virus. And we've also seen on social media that this is changing the way people are talking about healthcare. There are many accusations of expressed in anti-foreigner sentiments or accusations of the international global health effort being malintentioned towards people that sometimes can feel really scary when we read this. And I think this is something we really need to think about, of how this may be transforming the world, because at the end of the day, it will be the frontline health workers that will most feel this changing atmosphere, and that ultimately will pay the price. And this is why I really thank you all for being here today and to help us think of what we can do about these subjects and how we can make sure that we find adequate measures to address this violence against health workers. That has to stop. Thank you.
Thank you so much. Trying to make sure my video comes back. Thank you so much, Christina. I am now very pleased to introduce our government co-sponsors. Thank you so much for being with us. Actually, the first one is not literally a government co-sponsor, but is a very strong partner, non-governmental organization supported by the government of Poland, Małgorzata Olasińska-Chart. She's the director of Humanitarian Aid, which is a program in the Polish medical mission. And her organization runs projects in Iraq and Jordan for Syrian refugees in close partnership with the Polish government. I also want to acknowledge the support of all of today's co-sponsors before I introduce you or turn the floor over to Małgorzata. There are many coalition members and other governments that have supported this, and we're really grateful because, as Christina has just said, this effort, especially now with the COVID pandemic compounding all of the underlying challenges already there due to attacks and conflict, we really need to work globally in concerted action, governments and non-governmental organizations together. Małgorzata, welcome.
Thank you. Thank you very much. I am really honored and pleased to present the statement of my country, Republic of Poland, as well as of other NGOs, Polish Medical Mission that I am working in, and others working in COVID response and humanitarian aid in the health sector. For Poland, providing good, accessible and reliable healthcare, as well as the safety of healthcare workers, have always been one of the priorities as far as development cooperation is concerned. We are aware that especially in this sector, the gap between demand and response measures keeps widening. We also take every opportunity to stress how important it is to ensure safety and unhindered access of healthcare personnel while programming and implementing humanitarian actions. Violence against or obstruction of healthcare not only result in tragic consequences for people serving others, but also in further devastation of fragile health systems of the countries in crisis. This safety has become especially important over the past few months when many steps were taken to respond to COVID-19 pandemic. Needless to say that COVID-19, which has become one of the biggest humanitarian challenges, made the healthcare personnel extremely prone to risk while performing its duties. We all note with sadness that many of them pay the highest price while trying to save lives of others and alleviate the suffering. Poland attaches great importance to humanitarian and rescue aid operations conducted in crisis situations. Many times we face situations in which a country or a region affected by certain crisis is unable to cope on its own. Therefore, it is important to provide functioning and continuous improvement of international relief and civil protection systems. It is context of UN OCHA, INSARAC Group's Union Civil Protection Mechanism, and NATO's Euro-Atlantic Response Coordination Center should be mentioned here. Poland is aware that the current situation requires urgent actions to mitigate the devastating consequences for both the public health and the economy worldwide, in both developed and developing world. With this in mind, Poland reviewed its 2020 Development Cooperation Plan, including humanitarian aid response, focusing mostly on those aspects that will help to fight COVID-19 and its future consequences, and supporting those projects executed by the partners. With the support of Polish Ministry of Foreign Affairs, Polish Medical Mission, and other Polish NGOs, continue its actions by providing medical services, as in Baharka, Harsham, and Kushtaka camps for internally displaced persons and Syrian refugees in Iraqi Kurdistan. We follow all safety, health, and protection measures with the aim to deliver high-quality healthcare to all the camp's residents, with the minimal risk of COVID-19 spread. In Jordan, Polish Medical Mission provides medical services for those most vulnerable, women, children, and disabled people of Zarqa and Al-Mafraq provinces. Thanks to mobile health clinic, local population, as well as Syrian refugees, can have access not only to doctors and nurses, but also are taught how to prevent the other diseases. Another Polish NGO providing assistance under Polish aid program in Iraqi Kurdistan, Club of Catholic Intelligentsia, has modified its project implemented in Dohuk region in order to prepare the residents of Kaudia camp to counteract coronavirus spread. 37 women will sew 20,000 masks, which will be distributed in the camp and the village of Sharia. The project not only helps people to protect themselves against COVID-19, but also creates unique employment opportunities for women included in sewing. Polish Medical Mission is serving those the most in need, also in Syria and Venezuela, where COVID-19 is the highest risk for the population stressed in little territory of Idlib. I would like to share the picture of our work. I hope. Polish Medical Mission is distributing hygienic kits with the local population in Idlib camps among Syrian population. It's about 1 million children gathered in the provisional camps. We are financing education and information campaigns with the Syrian doctors that we are working together in the partnership. We are covering also the isolation centers, very provisional, to protect those and to keep those that are affected by COVID far from their families and relatives, to keep the other population safe. We also provided our doctors in Syria with the medical equipment that can help to deduct who is affected by COVID and who should be isolated. It is very difficult work for us, for our doctors, nurses, but we continue since 4 years providing medical help in Syria. In Venezuela, the situation is also very, very tense. The country is in the huge economic crisis. I was there in March, and in the days when the borders were closing and the flights were canceled, and I was desperately trying to get out of Venezuela. Finally, I did. But I saw the total collapse of medical system in the country. I saw empty refrigerators with no vaccine against any contagious disease. I saw doctors crying, having nothing to cure the patients, and with the COVID, even the situation worsened. So I am very pleased to say that Poland and Polish NGOs are doing all they can to provide protection and medical aid to the most affected populations. Thank you very much.
A model of responding in these desperate circumstances, and there's so much more needed globally, and especially what we're presenting today in this report is how systems are so weakened when they are attacked and undermined, and when health workers come under attack. Before we turn over to questions, and I want to make sure we leave plenty of time for that and a discussion, I'm very pleased to welcome Ambassador Luis Bermudez, who is the Deputy Permanent Representative of the UN Mission to the United Nations of Uruguay. Welcome, Luis.
Thank you, Susanna. I would like, first of all, to thank Safeguarding Healthcare in Conflict Coalition for inviting us this morning and to co-sponsor the event, and congratulate them as well for launching its annual report. I would like to extend our gratitude to our speakers this morning, and especially for being the voice of thousands of brave humanitarian health workers that are helping others around the globe. There is a critical and urgent point that stands out from the briefings this morning. Greater protection must be guaranteed to healthcare in conflict zones. When conflicts and pandemic intersect, this protection is more needed than ever, but paradoxically, medical workers and health are more targeted than before. The recent attack on a maternity hospital in Kabul that claimed the lives of mothers, newborns, and members of the health staff shocked the international community and could be the landmark for cruelty this year. 4 years ago, Uruguay actively engaged with other 4 elected members of the Security Council in a negotiation of Resolution 2286. We were very confident and enthusiastic at that moment, and we waited with hope that its adoption would lead to the effective protection of hospitals and medical workers. However, we witnessed with disappointment and regret that parties to conflict continue to carry out indiscriminate attacks and bombings against medical facilities and personnel, blocking humanitarian access and illegitimately removing medical items from convoys needed to provide care to vulnerable populations. In first place, it is imperative to redouble efforts to implement international humanitarian and human rights law, as well as Resolution 2286. Secondly, states and non-states groups should make every possible effort to put into practice the Secretary General's call for an immediate global ceasefire to focus on fighting the pandemic. Thirdly, the use of explosive weapons in densely populated areas should be avoided. These attacks take the lives and cause injuries to health workers and innocent civilians, and the reverberating effects of these attacks also represent a serious collateral damage to essential medical infrastructure. Fourthly, COVID-19 has led to a rapid digitalization, and with this to new forms of aggression. During the pandemic, an increase in the number of malicious cyber attacks against medical facilities has been reported. Measures should be taken to tackle these new types of aggression that are seriously impacting to access to health and hindering the provision of essential medical services. And finally, I would like to stress the importance of investigations and accountability of those responsible for perpetrating attacks against healthcare. For that purpose, detailed and reliable data collection will be crucial. once again, we think that Safeguarding Healthcare in Conflict Coalition report represents a valuable tool as a source of information on incidents against healthcare, taking into consideration the complexities of data collection in conflict settings. I will leave it here right now. I'm looking forward for the Q&A interactive segment. So thank you very much once again, and all the best.
We will be discussing a lot of the issues, I hope, right now in the next 20 minutes. Just to let our audience, our viewers know, we plan to continue till a quarter after the hour. So if you have questions, you can enter them through the Q&A button at the bottom of your screen if you're on Zoom. Since you raised the question of impunity, Ambassador Bermudez, this is something, of course, that has been a center of attention for the coalition. And as you probably know, particularly for Physicians for Human Rights, as we work internationally on the effort to assure that there is accountability. And we haven't seen a lot of it, even though, as you note, in Resolution 2286 that the United Nations Security Council passed, prosecuting perpetrators of the most egregious crimes that involve attacks on healthcare workers and facilities is the commitment of governments, and we have failed. The world has failed miserably in this. So I would like to address the first question. I think to you, Zaher. I have quite a lot of questions here from us, as well as I hope from others who are watching. But this first question actually comes from one of our coalition partners, Medical Aid for Palestinians. And the question is to the panel that you will recall the killing of paramedic Razan al-Najjar by Israeli forces in Gaza in 2018. And despite the international outcry at the time, nobody has yet been held accountable. Could you expand on how you think justice and accountability might be kept alive for cases highlighted in previous years by the Safeguarding Health in Conflict Coalition reports? And I assume that this question is first about this one case, but also about the large number of cases everywhere where, unfortunately, we see impunity. So over to you, Dr. Sahloul.
I mean, that was a very painful incident. I still remember what happened to Razan, her picture, the fact that she was trying to help people who were injured. I was in Gaza in February, actually, of this year, and spoke with the physicians who know Razan very well and her family. And unfortunately, as you've mentioned, that there's no accountability until now for this crime. We've seen what happened in the last couple of weeks after the murder of George Floyd in Minneapolis. This murder that was taken, recorded on camera, would have been just another incident by police brutality. But because of the outcry that we were seeing it translated into demonstrations and protests, and not only Minneapolis, but Washington, D.C. and Chicago and L.A. and Texas and North Carolina and Berlin and London and even Syria, then the world is paying more attention. And now it looks like accountability for this crime will happen, or more likely will happen. So unless the international community, and what I mean by the international community, not only governments, but civic society and medical organizations that have been very silent, except for the Safeguarding Healthcare and PHR and some few medical organizations, silent on the attacks on healthcare providers in Syria and Yemen and Afghanistan and other places, then accountability will not be seeing life. Every medical organization, national and international, should be dedicating large chunk of its energy and resources and conferences to talk about these issues and to talk about how can accountability and justice be done. So that way Razan and Dr. Al-Arraj, whom I know in Syria, and Dr. Al-Tamma, and many physicians in Yemen and Syria and Afghanistan, and nurses who were killed. At one point, their families will see justice.
Thank you. Others who want to comment as we go forward, feel free. Just to note that this year, following appeals by many organizations, the UN Security Council launched a board of inquiry to look at some of the blatant attacks in northwest and northeast Syria, even in the face of NGOs, humanitarian organizations, sharing their coordinates with the United Nations to protect them, and instead they were blatantly attacked by the Syrian government as well as their Russian allies. And unfortunately, we've seen that the UN Security Council is paralyzed in the face of efforts to make referrals, certainly to the International Criminal Court, which failed, which is where we believe those cases belong, but also accountability in so many other places. It's something that we will all continue to pursue. Len, I have a question for you, which is about the evolution of the toll that the Safeguarding Health in Conflict Coalition annual report has documented. And in this report, we note an increase in the reported incidents since last year. And I'm wondering if you think that the attention now to health as a result of the pandemic, even though now, based on what Christina showed us, the increase is even more dramatic due to a variety of factors, including the attacks on people who are trying to help people in the pandemic. Do you think there's an opportunity now for even greater attention to this issue as incidents rise? And what is the opportunity that you see to get change here?
We certainly hope so. When we look back 5 years ago, 6 years ago, this issue received very little attention. Violence against healthcare was not on the international screen and was not a major human rights or humanitarian law issue except among a few organizations. Now we're becoming more aware, and through the leadership of states like Uruguay, we have a UN Security Council resolution, but we don't have implementation. I think what's happening now is showing how pervasive and persistent these attacks are in all kinds of contexts. And we can hope that the medical community, the nursing community will express solidarity, and all the people, citizens of countries who have admired and celebrated health workers in COVID-19 will also be motivated to put pressure on governments to stop these attacks and hold people accountable. So I think we have an opportunity here right now. We have to take advantage of it.
Thanks. I hope we can, indeed. Christina, you were really the data head here in this group, and I'm wondering if you can talk a little bit about what is missing. We have only 20 countries that we've managed to cover in this report. Are there countries where we tried to gather data and we just can't get it? And also, who do you think should globally, we get this question a lot, at the international level, or is there any international governmental organization that should be documenting these cases? And if that's not happening, why not?
Yes, thank you for this important question. First of all, I would like to say, related to the issue we've just been discussing on how can we end the impunity. I think cases that are brought to the attention of prosecutors, but we also need the data that tell us about the patterns and the numbers, because it is that also helps to mobilize a wider community. And that's why I think it is so important that we pay enough attention to how we get these information on incidents. And it is very difficult because in some countries like Syria, there have been excellent communities of health workers and others who've collected that information, including Physicians for Human Rights, and SAMS. But there's other countries where the data flow is much, much more difficult. And I'm thinking, for example, of Burkina Faso or Cameroon. We know that there are big issues, but it is much harder for affected communities to share their experiences for a number of reasons. And so I think there is a huge task ahead of us to build better networks to connect people, that they can share their stories and that we can make sure they're brought to the international attention. And then finally, we do really need the international bodies to document these cases and to talk about the numbers, because that's when many bodies really listens. And I think in this context, we really have to mention the surveillance system of attacks on healthcare run by the World Health Organization. That has been a fantastic resource in bringing attention to the subject and also to documenting cases using networks. But it is extremely hard work for the WHO, and it's I think it'd be very important for this to continue. But if I could add another wish for the future, it is also really important that we understand who the perpetrators are, because if we want to end this impunity, we need to know who's doing it. And so I think there is many challenges we still need to resolve around how data is collected and how we share the information about the collected data.
Thank you. Very important point. As we know at PHR, we've worked intensively to try to include that in the documentation, that we do investigations as to the perpetrators. And it's not easy work, and it should involve many other NGOs who are focused on that. I'm going to do one more quick question before we turn it over to Switzerland, our friends in Switzerland, from Switzerland, to close. This is back to you, Len. And you sent out a very strong tweet last week when a US military helicopter carrying the Red Cross emblem for medical care hovered over peaceful demonstrators in Washington, D.C. as a show of force. And I'm wondering if you can talk beyond that incident, how this sort of violation affects efforts to protect healthcare workers, or actually puts them in more danger. And of course, this is something that our friends at the International Committee of the Red Cross and the Healthcare in Danger Project have also talked about extensively over the years. It's probably a good question to have before we have the Swiss with us.
Yeah. The misuse of the Red Cross emblem is, of course, and beyond that, the idea that you would use a Red Cross marked helicopter to intimidate demonstrators is a terrible act. But this raises a broader question about the abdication of responsibility to follow through on Resolution 2286, that countries are supposed to reform their security practices, military and otherwise, to implement rules and procedures for protecting healthcare, not just not attacking the hospital, but making sure in all their work they adhere to requirements to protect healthcare. And that extends to things like arms sales, which are sold to perpetrators, as the UK and the US did with respect to Saudi Arabia's violence air campaign in Yemen. So the ultimate issue is that these countries need to take their obligations seriously, so that situations like the use of a helicopter to intimidate demonstrators does not take place, much less that it has a Red Cross on the helicopter. And once that process begins, we'll have far greater protection. It will be an invisible kind of reform, because you don't see violations that don't happen, but it could have profound impact on protection of the wounded and sick and health workers. Thanks.
Thank you. I think we have a minute or two, so I do want to, just while we've been speaking in the last few minutes, two other very good questions came up. So if one of you on the panel wants to raise your hand before I introduce our representative from Switzerland. The first question, and maybe just really short answer, a 15-second answer, and we can answer more through correspondence and on the chat line before we wrap up. But the first one is, can you comment on how the report methodology has evolved over the years and whether we can compare year to year? Is there a quick answer for that, either Christina or Len? Just 5 seconds.
We try our best. I hope we get better every year, and I think you can compare our efforts between the years, most of all. And maybe you can also see that issues are particularly in one country at a particular year. But I would not take the total numbers as an indicator of the problem getting worse or better.
Right.
Len?
And this indicates the challenge that we have, that data are just incomplete. And as many have said on this panel, one of the primary needs and gaps is good data and comprehensive data and systematic data. Len, do you want to say anything more on that one?
I think Christina handled it well, and whoever had questions about methodology, I think you should contact us by email and we'll try to address them.
Great, thank you. We'll post the email address for the coalition here, or your email, Len. And then this one, unfortunately, you mentioned it in the beginning, Len, but it really would take a whole new seminar, which is, what are the key factors driving the targeting of health workers in the COVID-19 era, and what can be done? I'll just mention that Physicians for Human Rights colleagues, together with the International Council of Nurses and the World Medical Association, had a commentary in Lancet last month that addresses some of that. And I would also refer you to a Healthcare in Danger project on the ICRC website, which also gets at some of those factors. But maybe, Zaher, I'll let you have the last word on this, since we haven't heard from you in a few minutes, before I introduce our representative from Switzerland, and then we'll move on. Very short, if you can.
The attacks on healthcare provider in the time of COVID.
What is motivating it? What's driving it? Why is this happening? If you feel like answering that, or I know a lot of us have ideas, but.
I think it's a multiple factors. I think one of the main issues is the mental health trauma related to the COVID and the lockdown, and the fact that people are losing their livelihood and losing also their loved ones in the hospitals. And that is translated into sometimes abusive language against healthcare providers who are blamed for the death of family members. Stigmata also related to the fact that people associate now healthcare workers, especially in some countries, with spreading the virus. All of these are causing more attacks on healthcare provider. And this is something that we have to address, especially the mental health consequences of the COVID pandemic in many areas.
Absolutely. And as our article, our commentary mentions as well, unfortunately, in far too many countries, due to lack of investment and support of the health system by governments and others, there is a lack of trust in the health system itself that has let them down so many times in so many places. And so there's hostility, as you mentioned, which is something that also needs to be addressed by a massive, deeper public health response, I think, that the world has recognized has been lacking in the face of the pandemic. So to close today, I'd like to invite Dominique Favre. He's the deputy permanent representative of the permanent mission of Switzerland at the UN. Dominique, welcome, and thank you for joining us, and for all the support that Switzerland has given to this issue.
We are delighted to provide you with this support, and I would like to congratulate you, because I'm really amazed about the commitment and the engagement of all of you and the important work that you do. I think this was one of the best Zoom moments I've had since the beginning of the COVID, because also I have the feeling that you tackle really essential topics, and I'm a bit afraid when I listened to the realities in Yemen, in Libya, or elsewhere that you were describing, and I can only encourage you to continue your important work. In this sense, Switzerland is very proud to support the coalition in its important endeavors, and would like to express its gratitude for the important work this network of civil society actors is carrying out around the globe and all around the year. We have had the chance of inviting the coalition to present its work last year in Geneva during a meeting of the UN Security Council Resolution 2286 informal group. Your engagement and thorough analysis of this critical issue resonated within the members of the group. Let me be clear from the outset, the protection of the medical mission by all parties to armed conflict, governments and armed groups alike is enshrined in humanitarian law since more than 150 years. It is one of the basic values of humanity to protect the persons hors de combat, the wounded and sick, including from the adverse side and including those who provide medical assistance. The legal framework is universally accepted. What is needed is sound and coherent national implementation, including in laws, manuals, and practice. This requires stamina and political will. 4 years ago, the Security Council has adopted this resolution I was mentioning before, 2286, which called, among others, for strengthening domestic frameworks, military doctrine, training and investigation procedures, as well as accountability mechanisms. 4 years later, we are still in the process of documenting horrendous acts, which all too often undergo with impunity. The short and long-term consequences of attacks on the medical mission are also evident. We see health system collapsing with more and more casualties who could have otherwise been saved. The pandemic has displayed the seriousness of the matter. On one hand, we all applaud the health personnel who are doing their utmost to save lives, especially nowadays. And on the other hand, the number of attacks and the medical missions is on the rise, including cyber attacks. Even if the report covers 2019, it shows, for example, the enormous price of violence in the fight against Ebola during last year. It is the appropriate moment to cite Florence Nightingale. She said, "I attribute my success to this. I never gave or took an excuse. Neither parties to armed conflicts nor we all have excuses. We must act and protect the medical mission in all circumstances." Thank you very much for your attention.
Thank you so much. We greatly appreciate that you closed with the quotation of a nurse, since this is the time and the report that is dedicated to nurses. As the mother of a nurse who has also been doing COVID intensive care unit response, I'm very aware of the challenges that nurses have faced, both here in the United States and all around the world, but especially in the places where the bombs have destroyed the hospitals as well. I want to thank all of you for joining us today, for participating in the discussion, for speaking, for working on this report. I urge everyone to download the report. It's just, the link has just appeared in the chat. I think you'll see it widely through also the Safeguarding Health in Conflict Coalition website, which we hope you'll all follow, as well as the many NGOs that are part of this coalition. And a special thanks also to the governments of Switzerland, Uruguay, and Poland, as well as Norway, for your support. And we know you have a lot of work to do at the United Nations, and in coordination and urging each and every government to do what the resolution 2286 to protect health and conflict has asked of us. And to all of us public citizens of the world, we have our work cut out for us. Thank you very much. Stay healthy, stay strong, stay committed.